All right, welcome everybody. See, people are coming into the room. We're happy to have you all here again for, wow, the fifth session of Mini Med School. We are just like plowing right through this series, and I'm loving it. Thank you so much for being here once again with us. We're so happy to have you. My name is Summer Connery. I work for the Department of Graduate Medical Education for UCSF Fresno, which, say it with me, is the largest physician training program between Sacramento and Los Angeles. Woo woo! Something we're very proud of. We're back for session 5 of 6. Next week will be our final of the series. And not to worry for all of those that were asking about certificates, we are going to give you a link. I'll probably send it out to you on Friday, but we'll send it again to you on Tuesday of next week when we have our final session about the certificate and about a raffle. So that information is coming. Not to worry, you will get it. If you miss anything in person, go ahead and go back to YouTube. Let me give you that link right now in case you want to go back and watch anything that you may have missed. So I'm going to go ahead and plop that into our links here. Okay. And then in just a second, I'm going to pass it over to Dr. Dillon. We know her. We love her. She's an emergency medicine faculty at UCSF Fresno and also works for the Fresno Department of Public Health on various guidelines, protocols in response to COVID-19 in Fresno County. We need her right now just for that reason. A fun fact about Dr. Dillon, she's visited 17 national parks. Her favorite was Yellowstone. Okay, but that's only so far. She still has many to go, and her goal is to see them all. So, Dr. Dillon, we'd love to hear more about your adventures. Take it away.
Oh, yes, they were amazing. We love, all our vacations are pretty much hiking and camping. I think one time we went to a city and we didn't know what to do. We were so lost. So I'm gonna quickly do a poll everywhere, and then I'll introduce Dr. Keel to everybody. So like we always do an icebreaker, so I'm gonna share my screen real quick. This hopefully is a fun question. Here we go. Hopefully you can see it. What is your favorite midnight snack? Remember, you can go to the website, poll everywhere, or you can text, which you should have on your phone already now. Chips, ahoy. All right, ahoy chips. Yep. Cereal, yes. Those Honey Nut Cheerios cereal, so good in the middle of the night. Cookies, popcorn, perfect. Cereal is a big hit. I love fish chips.
Still cookies.
Ice cream. How come ice cream is not winning? I love it. All right, I guess. Here we go. Finally.
Where are my Takis? I thought people were going to be saying Takis.
I know, there's no Takis.
No Takis.
There's Cheetos. Perfect. That's awesome. Yes. If I could have fries in the middle of the night, I totally would. And here you go. Takis. Perfect. Making all of us happy. Thank you, guys. I am going to go ahead and stop sharing my screen. Welcome back, everybody. I am going to go ahead and introduce Dr. Keel. And I actually learned something really interesting about him today, which I'll share in a bit. But Dr. Keel actually received his medical degree from Drexel University. And then he did his residency in internal medicine here at UCSF Fresno, followed by fellowship here as well in adult cardiovascular disease. And then he went to the main campus at UCSF for advanced heart failure and cardiac transplant fellowship, which is amazing. So he's board certified in internal medicine, in adult cardiovascular disease, and then in advanced heart failure and transplant cardiology. He's our LVAD guy here in the Valley. He's awesome. It's so nice to have him. You know, we can always call him. He's very approachable. So that's been really nice, especially working in the ED. He's earned many honors, including American College of Cardiology, California chapter, Excellence in Cardiology Fellowship Award, and the Central California Veterans Hospital Excellence in Physician Values Award, which is amazing. Fun fact about Dr. Keel, he and his wife are local, which I did not know that till today. That's amazing. He went to Yosemite High himself, and his wife went to Bullard High, and then he went to Fresno State. So that's where I went, which is amazing for undergraduates. So that's pretty cool. Dr. Keel, I am gonna let you take over. Thank you for joining us today.
Oh, thank you, Dr. Dillon, and thanks for the very kind introduction. So
For sure.
I didn't know that you were a bulldog as well. So
Yes, totally, that connection, yes.
I love it. I love bringing it back to the Valley.
Totally.
That was kind of my goal as well, was to always come back and try to give back to this community.
Yes.
And I think this is an exciting way to do this. So let me try to share my screen again, and I hope I didn't screw it up. This again, and try to share my screen. Okay.
We can see it.
Okay, how's that?
Yep, looks good.
Okay, great. All right. So sorry about that. So my name's Richard Kiel. I'm a cardiologist here. Obviously, I'm not an IT expert. I really wish that Leland was here in person, but we're all doing this. We're all learning this together, sort of from our new virtual roles.
Yeah.
And so, as Dr. Dillon had said, I'm the director of heart failure here, and really focusing on kind of advanced heart failure patients, mechanical hearts or left ventricular assist device, and taking care of heart transplant patients. And so I really wanted to talk to you guys today kind of about what is heart failure. I know this term gets sort of bantered about a lot, and a lot of people don't really understand what it means. What are some of the common signs and symptoms? How do we actually make the diagnosis of heart failure? What's the effect of heart failure on our body? How does it cause us to feel ill, give us the symptoms that we experience or that our loved ones or friends might be experiencing? And then, something in particular that we kind of have a lot of experience here with, unfortunately, is really what's the role of amphetamine abuse and how does that lead to heart failure and what can be done about that? And then we'll talk about some of the treatment options. But I wanted to leave plenty of time for questions. And so we are already, I think, 11 minutes behind schedule. So we'll try to hustle through this first part. So it's hard for me to talk about heart failure without talking about how important it is to not only us here in the Valley, but sort of as a society, because heart failure is the #1 reason that patients get admitted to the hospital. If you look at Medicare patients, about 1 in 4 patients that are ever in the hospital at any given time are there for heart failure. It affects about 6 million adults, so about 1 in 5. It's about 5%. And it's a very serious diagnosis. Whenever I talk to my patients about heart failure, I really try to compare it to cancer because just like cancer, it's a serious diagnosis that requires serious treatment. And just like cancer, if untreated, most people will die within 5 years of developing heart failure. It's a super expensive disease process. We're talking about more than $40 billion per year in the United States are we spending on heart failure alone. And as you can imagine, in this day and age, we're really looking at skyrocketing premiums. It's important to really try to minimize the cost to the system. And so when we talk about heart failure, what are some of the risk factors that we have? So the most common risk factor for developing heart failure is age. So not a lot that we can do about that. If I can find a treatment for age, I probably wouldn't be sitting here right now. I'd be giving this lecture from a yacht somewhere. But more common reversible symptoms are high blood pressure, blockages in the arteries of the heart, or what we call atherosclerotic cardiovascular disease, diabetes mellitus, obesity, inactivity, and obstructive sleep apnea. And so a lot of those things are probably disease processes that you're familiar with in one way or another. As many are aware, we're currently in the middle of a epidemic of obesity, diabetes, and hypertension. And it really affects this community, this area disproportionately. And as a result, we see more than our fair share of heart failure as well. Kind of focusing down, looking at just sort of a map of the country, where is heart failure affecting communities more significantly? And as you can see, really in the South, we have just a very dense population of people with significant obesity, diabetes, hypertension. coronary artery disease, lots of risk factors. So you see this sort of southern belt of very densely populated areas that have a lot of heart failure in them. Looking at California, California in general tends to do a little bit better than the rest of the country when it comes to heart failure deaths. But if you focus in on the Central Valley, this little boot-shaped area here is Fresno County and our surrounding areas. We tend to be more affected by heart failure than other areas in the state. And certainly we're responsible for many of the hospitalizations and many of the deaths that result that are caused by heart failure. And this is looking at deaths caused by heart disease in San Joaquin Valley, and just looking between basically the new millennium all the way up to 2018. And as you can see, across the boards, we've done a better job of improving outcomes when it comes to heart disease. This dense line here is sort of the death rate from heart disease in San Joaquin County, which is sort of representative of the San Joaquin Valley, with these lines representing sort of the United States in general and California. As you can see, the lowest line is California, meaning that deaths tend to be the lowest here, lower than the United States. And for a long time in Central Valley, the mortality rate for heart disease was well above that of California. Over the last 10 years or so, we've done we've made a lot of strides trying to improve those results and get them closer to representing the United States in general and more of California. And we've been somewhat successful, but we certainly have more opportunity for improvement. So that's kind of sort of set the stage for why heart failure is important, why we need to talk about it. But really, again, I think the most important thing is to allow you guys to understand kind of what is heart failure. And so, a very wise man, somebody kind of wrote the textbook on heart failure. His name's Gene Braunwald. He's a Harvard cardiologist and really sort of set the stage when it comes to the understanding of heart failure. So he defined heart failure as a clinical syndrome characterized by known symptoms and physical signs. It's the pathologic state in which an abnormality of myocardial function or structure is responsible for failure of the heart to pump blood at a rate commensurate with the requirements of the metabolizing tissues during ordinary activity. So that's really fancy doctor talk, but basically what he's saying is that for whatever reason, there's an abnormality in the way that the heart functions or the structure of the heart itself. So it could be that you have an enlarged heart, a thickened left ventricle or pumping muscle of the heart. Maybe there's a sticky or a leaky valve. But for whatever reason, the heart, whose sole purpose is to really push blood through the body, is not able to push enough blood through the body to carry the oxygen to the cells of the body that really need it. And again, this is just sort of clarifying the diagnosis. So it's important that we get blood to the organs because the blood is what carries nutrients and oxygen. As you can imagine, if you're sitting there at your desk looking at this lecture, you're not really burning a lot of energy. You're not requiring a lot of oxygen. You're not requiring a lot of energy. But the more activity you do, the more your body needs. The heart normally can adapt to provide an increased availability of nutrients and oxygen. However, if the heart starts to fail, it's limited in its ability to adapt to stress or exercise. So people become much more symptomatic, develop shortness of breath or fatigue with activities that normally wouldn't cause people to have any trouble. This change in blood flow ultimately results in the symptoms of heart failure, and it can change some of the hormone levels in the body, which we'll talk about in just a sec. I wanted to start by just sort of going over a little video, and I hope this works. So I don't know where it's going to. Here we go. This is on YouTube, so it's publicly available. Any of you guys can look it up. And, all right.
Imagine the places we'll go.
Well, here's a video for Expedia. If any of you guys want to go on vacation, Expedia is a wonderful site. Hopefully they can give us some money for that commercial. All right, let's see if this plays. Oh, no. Okay. Well, we'll just skip this. There's a couple of videos here. I was hoping to give you guys some physical examples of kind of what heart failure looks like, but we'll just have to use our imagination. And I think I like to use the analogy of a pair of bellows. So I don't know if any of you guys are old enough, like I am, to have ever used bellows for a fire, but a bellow is a sort of a relic of a bygone era. But it's basically an accordion style pump, which is designed to push blood through or push air that comes in through a little nozzle and through a little valve out through a nozzle. And this basically pushes air, and it's used to stoke a fire or for other reasons, to provide airflow for an accordion or other similar instruments. And it's very sort of analogous to the heart. You can imagine the heart basically has multiple chambers: the left ventricle, the right ventricle, the left atria, the right atria. And these squeeze, the walls come together, it actually torques down, collapses sort of on itself, and the walls thicken to squeeze blood. And all of that sort of pushes blood through the arteries of the heart: the pulmonary artery, which carries blood from the right ventricle to the lungs, and the aorta, which carries blood from the left ventricle to the rest of the body. So this takes the deoxygenated blood, pushes it through the lungs, where it can exchange the carbon dioxide and other gases for the oxygen that we need. It dumps it basically into the left atrium, which then sort of primes this left ventricle, which is the main pump of the heart, and that pushes it through the aorta, where it goes to the extremities, the brain, the kidneys, the liver, and all of the skeletal muscles. And all of these pumps sort of work in concert to provide a steady availability of blood to the body. As you can imagine, if your accordion or your bellows were very stiff and you could not really squeeze them together, not a lot of air would get out of that nozzle. Or if you couldn't open it up fully and you can only open it up very slightly to push, a little bit of air comes in, a little bit of air goes out. Either way, you're not able to deliver a lot of air to stoke your fire. The heart's the same way. There's multiple types of heart failure. The most common one that we think of is what we call heart failure with reduced ejection fraction. And that's where these ventricles, particularly the left ventricle, doesn't really squeeze well. The walls don't thicken as much as we would expect to. The walls of the heart don't come closer together. And just like that bellows, it's just not pushing a lot of blood forward. It gets plenty of blood into it, usually more blood than it needs. And that's what we mean when we say the heart's enlarged. Over time, with a lot of increased pressures in the heart, it starts to stretch out and get just basically larger. And so, because of that, it's not delivering a lot of blood flow to the body. Another kind of heart failure that we commonly deal with is what we call heart failure with preserved ejection fraction. And that's basically a stiff bellow that you can't open up well. So the heart itself, the squeeze works normal. It's able to pump, often what we call the ejection fraction. How much blood is pushed out every time the heart squeezes is normal. 50 to 60% is probably what most of you guys have. However, with some longstanding disease, diabetes, hypertension, over time, the heart muscle itself can thicken and become stiff. And as a result, it can't really open up wide to accept a lot of blood in. So you can imagine a little bit of blood gets in, only a little bit of blood can get out. The heart's good at pushing out almost all the blood in it, but at the end of the day, it's the same result. You're not able to get the blood cells to the body to get the body the oxygen and nutrients that it needs. And as a result, you develop symptoms of heart failure. For the men in the audience, and what I like to use with my men patients, I like to use sort of the analogy of a car. You can imagine that if you're in a car and it's designed to carry around a ton of sand in the bed, you need a big V8 engine, right? And your body's the same way. It's really built and designed to produce a significant level of work. Well, you could imagine if you took out that V8 engine and you put in a 4-cylinder engine, the car is going to be sluggish. You're not going to be able to do what you need to do. It's going to go slow uphill. And that's kind of the same thing with the body and heart failure. So how does this affect the body? And so this is kind of a busy sort of medical school slide talking about sort of the feedback effect of heart failure. And we'll really start with kind of what prompts the development of the syndrome of heart failure. And that's what we call a low cardiac output. A low cardiac output, is probably better described as just a low flow state. Your cardiac output is basically how much blood your heart's able to pump in a given minute. As the heart weakens or becomes more stiff, that number goes lower and lower. And the body senses that. The body senses that through low blood pressure, what we call hypotension. And also just senses the decrease in pressure that the weakened heart is not able to generate. And we have receptors that line the aorta, that main artery that comes off the heart. And we have receptors in the arteries of our neck, which can sense that low blood pressure. And it basically stimulates the brain to send out a signal. And the problem with sort of the brain's response to this is the brain doesn't know what's causing this low blood flow. And a variety of things can cause a similar signal. You can have a very bad infection, which lowers the blood pressure, and that can cause low blood pressure, hypotension, and low flow to the organs. You can have very significant bleeding, which lowers the ability of the heart to deliver oxygen to the body. All of these things can cause the same sort of signals. And so the body basically releases sort of a kitchen sink's worth of hormones to try to counteract the effect of heart failure, bleeding to death, bad infections. And as you'll find out, some of those responses actually just make the heart failure worse. So one of the first things that the brain releases is a bunch of stress hormones. These are what we call norepinephrine, epinephrine, vasopressin. These are adrenergic hormones, commonly referred to as adrenaline, noradrenaline. These are the fight or flight type of response that the body is designed to be able to provide in the setting of intense physical stress. These are medications which really cause the heart to increase its heart rate, to beat faster, to beat stronger. It causes the blood vessels to squeeze down, raising blood pressure. And in certain situations, that can actually be what we call adaptive or beneficial. So for example, if you have a very bad infection and you end up in the ICU of our hospital or in the emergency department with Dr. Dillon, often we're using these medications, norepinephrine, vasopressin, to increase your blood pressure to counteract the effects of that bad infection. Unfortunately, in heart failure, it really just causes the heart to require more oxygen itself, which will lead to sort of worsening of the heart failure down the road. The other thing that happens with a low flow state is we release a lot of hormones called Rasp Blockade. RAS stands for renin, angiotensin, and aldosterone. And these are the hormones that really regulate blood pressure and are responsible for high blood pressure in most people. And it has a very similar effect. It basically increases the blood pressure. It also increases the resistance or the work that the heart has to push at to get blood from the heart to the rest of the body, causing the heart to have to work overtime, require more oxygen itself, which will lead to the heart developing worsening symptoms, what we call apoptosis. The cells themselves in the heart start to die, making the heart failure worse. Another thing that's triggered, along with aldosterone, other hormones cause sort of reabsorption of sodium in the kidneys. And whenever sodium gets reabsorbed in the kidneys, water follows with it. And for any of you who have sort of overindulged and had a high sodium diet and noticed that you've got some leg swelling afterwards, the socks are making lines that they didn't used to make, I think you've seen the effects of this. And this can be very significant in the setting of heart failure and can lead to patients gaining 30, 40, 60 pounds worth of fluid to the point to where they're really not able to fit into their shoes or socks or their clothes anymore because they're so swollen. And this edema or swelling really leads to congestion. It can cause swelling, fluid retention in the lungs, which really triggers a lot of the symptoms of shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, which we'll explain in just a few seconds. And then sort of the last thing that the brain releases is a hormone called B-type natriuretic peptide, or BNP. Now, often physicians and doctors think that BNP is somewhat of a bad thing, because if a patient presents with rip-roaring heart failure, that number gets higher and higher. In normal people, it's usually 20 to 50. In heart failure patients, it's almost always over 200 or 300 and can often be in the thousands. But what we have to realize is that BNP is actually the only adaptive response that the body has to heart failure. BNP as a hormone causes decreased blood pressure, it relaxes blood vessels, it causes you to pee out salt water, and it actually helps the heart to beat more strenuously and more efficiently, which is basically sort of everything that we want to have happen in a heart failure medication. Unfortunately, in the setting of all of these other signals, the BMP tends to not live very long in the body and gets overwhelmed by all of these other signals. This sort of cyclical process really feeds back, makes the heart worse, which further lowers the blood pressure, further lowers blood flow to the organs, making the heart failure worse. These signals become louder and louder. And often this can be a very vicious cycle, which just causes worsening and worsening heart function over time. So what are the symptoms that we're talking about? So the most common symptom that I hear of, and what often gets overlooked, is just people have no energy. They used to be able to do a lot more, but for whatever reason, they might not be necessarily short of breath or swollen, but they just can't do what they used to be able to do. And I hear this almost every single day. It really, doc, it started out, I just wasn't myself. I just didn't have the energy. I just couldn't do what I used to be able to do. I can't put my finger on one thing or another. I just wasn't myself. So that's probably the most common symptom. Often also what people get is sort of a cough, particularly at night, as we start to lay down and the fluid starts to build up in the lungs. We can get what's called a nocturnal cough. We can get shortness of breath, and that shortness of breath again can get worse as we lie down and start to shift some of that fluid from our lower extremities, our feet and ankles, back into the lungs, back into the heart, making the heart failure worse. We can feel skip beats or very rapid heartbeats, what we call palpitations. Those can be symptoms of heart failure and often can be a sign of significant heart failure or arrhythmia, irregular heart rhythms, which can be triggered by heart failure. What we often think of is things like shortness of breath. Somebody would commonly tell me is, doc, I used to be able to exercise. Now I can't even bring in groceries from the car without getting short of breath. I can't walk up the 10 steps from my driveway to my front door without getting short of breath and having to stop and take a break. Or often, even if I'm combing my hair, getting dressed in the morning, bending over and tying my shoes, I'm huffing and puffing. As we talked about, we can get some swelling in the ankles, feet, and often what's overlooked is we can get swelling in the stomach. So women who have had children often collect fluid in their belly. They might have skinny ankles. You can't see any sort of swelling anywhere, but they look like they're 5 or 6 months pregnant. And men can often carry fluid in the belly as well. Often people will get loss of appetite for two reasons. One, you have to remember that the heart's not getting the organs the oxygen that it needs, and that includes the stomach. And as you're eating, the stomach requires more and more blood flow to be able to break down the food in the stomach and absorb those nutrients, and it requires more energy, and the heart just can't provide the energy that the stomach really needs to work well. So the food doesn't get absorbed like it should. It starts to build up in the stomach and cause what we call early satiety, or you just get full early. The other thing, as you're retaining more and more fluid, especially in the belly, the stomach itself can get swollen, making it difficult to absorb food and making this space inside the stomach smaller as well. So you just can't receive as much food. Another big symptom is rapid weight gain. And often, I'll have my patients and they'll gain 2, 3, sometimes 5 pounds in 24 hours. And that's usually associated with worsening symptoms, worsening breathing when laying flat, and worsening swelling. And you have to understand it's almost impossible to eat enough food to be able to gain that amount of weight in that short period of time. And really what we're talking about is just fluid retention. And lastly, another very frequent symptom of heart failure is frequent urination, especially what we call nocturia, or urination at night. And as we lay down and we actually reabsorb water from the feet, the ankles, the belly, and distribute that back in the blood vessels, the kidneys start to work a little bit of overtime, and you find that you have to get up frequently to pee. Okay, so it's important when we're starting to make the diagnosis to focus on the symptoms that are what we call more specific for heart failure, meaning that if you have those symptoms, you're very likely to have heart failure and less likely to have something else, and symptoms which are less specific. And that means basically symptoms that are associated with heart failure, but are also associated with a lot of other disease processes. So very specific symptoms of heart failure. The first thing is something called orthopnea. And that's that sensation that you get short of breath if you lie flat. and often happens at night and often leads to what we call paroxysmal nocturnal dyspnea. And that is waking up at night with the sensation that you're suffocating or drowning. And the mechanisms for both of these are fairly similar. For orthopnea, what happens is normally as we're sitting upright, sort of gravity takes all the fluid that's collecting in the body and tries to pull it as low as possible. And that's why most people will have swelling in their ankles before they have swelling anywhere else. That's because if they're on their feet, gravity's pulling that fluid down. We have to think though, in the lungs as well, it's doing the same thing, and it's pulling fluid, what we call pulmonary edema, or fluid in the lungs, from the top and middle part of the lungs to the base of the lungs. Well, normally we don't use the base of the lungs to really collect a lot of oxygen. Most of the oxygen sort of gets collected in the middle portions of the lungs. The top portions basically don't get as much blood flow. They get a lot of air. The bottom portions don't get a lot of air. They get more blood flow, but it's really the middle portions of the lungs that do most of the work. As we lay flat, that fluid that's normally collecting at the bottom of the lungs starts to get redistributed amongst sort of all of the zones of the lungs, all three layers, top, bottom, and middle, causing more shortness of breath. Also, as we lay flat and the fluid starts to get reabsorbed, that pressure starts to build up in the heart and build up in the atria of the heart, and that gets transmitted back to the lungs, causing the lungs to become even more swollen, develop even more shortness of breath, and people really do wake up and feel like they're drowning in their own bed. And often you'll have patients describe to you, well, I had to get up and walk around, I opened some windows, I went outside, and finally it felt better. And it's not uncommon at all for me to have patients that are sleeping, sitting upright in lazy boys or on the couches because they just really can't get comfortable laying in any more than sort of a 90-degree fashion. So those are very specific symptoms of heart failure. If anybody describes those to you, that should be your first and second diagnosis on your differential diagnosis, your list of sort of diseases that you're trying to evaluate for. Less specific symptoms. So these are things like fatigue. So yes, fatigue is the most common thing that I hear of, but it's also a common symptom for a lot of other issues. So you could have anemia and be fatigued. You could have sort of hypertension and be fatigued. You can have coronary artery disease and be fatigued. You can have sort of abnormal thyroid function and be fatigued. So even though it's common in heart failure, just by virtue of having fatigue doesn't mean that you necessarily have heart failure. Shortness of breath, likewise, is a frequently cited symptom with a variety of disease processes. As you can imagine, somebody has asthma, they're going to have shortness of breath, right? Doesn't necessarily mean they have heart failure, but for whatever reason, they're still not able to bring enough oxygen in. Chronic obstructive pulmonary disease, what we call bronchitis or emphysema, can cause shortness of breath as well. Same thing with swelling. I get a lot of patients who come to me and they're concerned that they have heart failure because they have swelling. Well, swelling can be a sign of, like we talked about earlier, abnormal salt intake. Certain medications can cause swelling, and sometimes people just develop it idiopathically, meaning that they just get it for no good reason. Same thing with decreased exercise tolerance, can be caused by a variety of different conditions, including heart failure, but not always heart failure. So we always try to pair sort of the symptoms and the history that we obtain with physical exam findings. So some very specific physical exam findings that we really find with heart failure and not with a lot of other conditions. The first one is what we call jugular venous distension. You can imagine the jugular veins, or the veins of the neck, and they sit next to the arteries of the neck, the jugular arteries. And the right jugular vein in particular drains directly into what we call the superior vena cava and then into the right atrium. So we're almost looking at a direct column of blood or water that's really sort of reflecting the minute-to-minute pressures in the heart itself. And we can see sort of how far these pressures are being elevated, and that can tell us if somebody's retaining too much fluid, because it'll stretch out the heart, and that pressure will start to build up, and it'll stretch out the veins of the neck, and we can actually see that on exam. I have, I think, a picture to show that. I have a video, but my guess is the video is not going to work. The other thing that we often find that's very specific is a displaced point and maximal impulse. Now, this is something that you guys can check at home. If you feel sort of on your left chest, kind of in what we call the mid-clavicular line, sort of if you go through the middle of your collarbone and go straight down, somewhere right underneath your left nipple, on the ribs, you should be able to feel sort of a thump, thump, thump. And that's what we call the PMI, or the point of maximal impulse. And that is literally the apex of the heart, the tip of the heart, that's contracting and hitting the chest wall. Normally, you'll find it in sort of this midclavicular line. As the heart gets enlarged, thickens, and dilates, gets bigger and bigger, that apex gets pushed more and more towards the side of the chest. And so it's not uncommon to have somebody have a point of maximum impulse, or PMI, that's all the way in the axillary line, sort of underneath the armpit. Very few things cause that other than cardiomegaly, or an enlarged heart. Another thing that we listen for is a third heart sound. So this is in addition to the normal lub-dub that you would hear. So lots of people have heart murmurs. They can be very benign, they can be very significant. But this third heart sound is basically the sound of a big column of water crashing into the heart. And it's because of all this fluid that you're retaining, the pressures build up, the valves open up, and blood just rushes in, and it sort of hits the wall of the heart and causes an extra sound. So it's dub, 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 lub, dub, dub, lub, dub, dub. Hearing that sound, you really know that you have increased blood flow to the heart, which is a very specific sign of heart failure. And then the last specific finding that we're going to talk about is what we call Hepatojugular Reflux. And that's when you apply pressure to the belly. That pressure increases blood flow to the heart, and you see the neck veins get even more distended. And after you release pressure, they stay distended for at least 10 seconds. If we see that, it's a sign of the body retaining too much fluid, and that's heart failure or other causes of fluid retention, but typically it's a stiff heart. So less specific findings, swelling of the ankles, like we talked about, can be caused by a variety of things. Swelling of the liver and spleen. Nocturnal cough often can be associated with asthma, bronchitis, viral infections. Crackles in the lungs, or listening to weird lung sounds, can be caused by infection, asthma, COPD, other causes. Putting them all together can help to make the diagnosis of heart failure, but it's not very specific for that. So this is just an example of that jugular venous distension that we were talking about earlier. So just breaking down sort of the anatomy of the blood vessels of the neck. Basically, this is the common carotid artery bifurcates into the external and internal carotid artery. And then you have basically an internal jugular vein and an external jugular vein. And that's what you're basically seeing here and here. This is your external jugular vein, and this is kind of your internal jugular vein. And as you can see, these veins just are really bulging. This is a thin-necked woman. You wouldn't expect to be able to see these veins unless somebody's bearing down very intensely. So everybody can kind of make their veins bulge if they're really pushing, they're straining, they're really pushing heavy weights. We're increasing pressures into the heart, and that causes the fluid to build up. But we shouldn't see these types of venous distension in the absence of physical strain. And often what we can see, especially if you have a very leaky valve, is that this distension will be shooting up and down the neck. Really what we call Cannon CV waves. And these are just big waves with a wide open valve that's just basically having blood rush into it every time that the heart beats. How much time are we at? So 15 minutes. Oh, we'll just skip the video. I don't think it's going to work anyways. Hepatojugular reflux, again, this is just an increase in the neck vein distension of more than 3 centimeters. So usually when you're doing this test, you want to have somebody sitting upright so you can actually see it somewhere above the clavicle or the collarbone. You want to see it raised for at least 3 centimeters after you put pressure on the belly for 15 seconds, and you want it to last for at least 10 seconds. We'll try this one. This is a really cool video. I just don't think it's going to show. Oh, hopefully you guys can see that. So again, applying pressure, and classically it's over the liver, but you can really put it over anywhere in the abdomen. Here you can see that distension really shoot up into the top of his neck. Let's just look at that one more time. So pressure on the belly, doesn't have to be a whole lot of pressure. And then you can see the jugular venous distension go from just above the clavicle, then with pressure goes all the way up to the angle of the jaw. And then if you hold pressure for 15 seconds, you release and it stays up for 10 seconds. That's what we call hepatojugular reflux. So here, I guess with this video, hopefully you can see it. You can see both the jugular venous distension and the Hepatojugular Reflux. Good. Dr. Dillon and Summer are nodding their heads, so hopefully you guys can see it. All right, well, I'm glad that one worked. All right, so this is my hobby. This is my sick little hobby. I'll sit there in Costco or Walmart and just look at people's legs, right? And as a heart failure cardiologist, I mean, the first thing that I notice is somebody who has swollen ankles, because I think, well, why isn't this patient in my office? I need to be seeing this patient. Let me go talk to this patient and get him scheduled for, for follow-up soon. So this is an example of pitting edema. So lots of disease processes can cause swelling of the lower extremity. Sometimes with like low thyroid, for example, you can get what we call mixed edema, which is really just swelling of the extremities, but it's very thick and it doesn't really indent. This is pitting edema. This is basically salt water swelling of the legs. And this is very profound, what we would call probably 3+ pitting edema. And all of you guys have probably experienced this from time to time. You get home, you've been on your feet all day, you maybe had some fast food for lunch, you go to take off your socks and you have lines on your legs. That can be sort of a normal finding throughout the day, though if it gets very, very significant, you probably want to talk to your doctor about it. But this is, is swelling that can occur with patients lying flat on their backs, haven't been on their feet at all, and you press down on their legs. Sometimes it's all the way up to their, to their thigh. Sometimes the scrotum can get swollen. Sometimes their rear end can get swollen, especially if they're bed bound. But you put your thumb down, you put some pressure on there for 10 to 15 seconds, and you have a divot that can last for sometimes several minutes. This is saltwater edema, it's swelling of the lower extremities. Now you can see it with, Dr. Roytman is going to talk to you guys, I would assume, about cirrhosis. And you can see this type of swelling with cirrhosis. But this is, again, something that often can trigger people to think, well, maybe congestive heart failure is contributing to this. All right, so trying to put it all together, and how do we actually make the diagnosis of heart failure? And again, we're thinking about the syndrome of signs and symptoms of heart failure that are demonstrating that the heart can't provide enough blood flow to the body. And so the Framingham Group, so this is a group out of sort of New England. It's a very famous sort of collection of people who have been actually followed for a long period of time. Actually, I don't think it's doing it. Anyways, it's a group of people, mostly white people, been followed through since the 1960s, 1970s. And over time, they were able to really sort of figure out different cardiac risks for these patients. And a lot of good research has been demonstrated out of this. And I think one of the things that came out of this sort of Framingham cohort is the diagnostic criteria for heart failure. So this is where we really focus on major and minor criteria. So major criteria are those signs and symptoms that are very specific for heart failure. And minor criteria are those sort of symptoms that aren't as specific, but sort of can add value to the diagnosis. So if you have two major criteria, you have cardiomegaly, so somebody has a displaced point to maximal impulse, they have neck vein distension, you have the diagnosis of heart failure. Now, it could be heart failure with reduced ejection fraction, preserved ejection fraction. It could be because of valve disease. We don't know, but you can definitely diagnose them with heart failure. And here's the other thing that we look at is somebody has sort of high blood pressure or goes into acute pulmonary edema and has signs of volume overload, a third heart sound, paroxysmal nocturnal dyspnea. That makes a diagnosis of heart failure as well. The other thing that we can do, and this is often what happens in the emergency department, you give somebody some intravenous or IV water pills. So something like IV furosemide, IV Lasix, IV Metonide, IV Bumex, and they lose 10 pounds by the next day. And this often happens. That type of response to diuretics really represents that the body's been retaining way too much fluid and is a very suggestive sign of heart failure. So you can have two major criteria or one major criteria and two minor criteria to make the diagnosis of heart failure. Now, if you don't have any major criteria, that doesn't necessarily mean that they don't have heart failure. It's just less likely to make the diagnosis, and you probably need to do additional studies, ultrasounds of the heart, blood studies to look for levels of that B-type natriuretic peptide. All right, so switching gears here. Now really talking about a very specific cause of heart failure. And this is amphetamines. Okay, so I want to tell you a story. This is, if you guys haven't been to this website, justthinktwice.gov, it's a great website. This is a site that's dedicated to people who have dealt with life stressors, substance abuse, and it's real people and their family telling real stories. And so I left the link to this story. This is Casey Hadel on the bottom, and it's a story that I think we're all going to find sad, but it's also a very typical example of the types of patients that we see here on a daily basis. So Casey was a high school senior, soon to graduate, honor roll senior. She was kind of very interested in journalism, started her own column in a newspaper. She was a basketball coach. She volunteered in the community, and she was kind of sort of what people would imagine to be sort of, the good student, the good girl, the good daughter. She had been accepted to Montana State, and again, her idea was to pursue a career in journalism. Her parents noticed that she was actually selected to do sort of a trip to Paris and study abroad for a few months. And prior to her leaving for that trip, they noticed that she just didn't look right. She was up all night long. She wasn't sleeping. She had lost some weight. She just looked tired all the time, and she was really just huffing and puffing to do stuff that normally wouldn't be expected of somebody. And they took her to one doctor after another, and they really couldn't figure out what was going on. Her sister was playing basketball. Casey went to watch her sister play basketball. She came home, collapsed in the living room. Parents didn't know what to do. They started CPR. They called 911. Paramedics came. They took her to the hospital. At the hospital, she was diagnosed with sudden cardiac arrest. What was described as a massive heart attack, but really what happened was the heart just sort of gave out on her, and she went into one of those irregular heart rhythms, something that we call ventricular tachycardia or ventricular fibrillation, and which is really just a short circuit of the heart, causing it to beat so fast that it really can't supply any significant blood flow to the body, including the brain. They found that she had methamphetamine in her system, and afterwards, after talking to her friends and some of her schoolmates, they were able to determine the fact that Casey, despite being an honor student, despite being kind of the ideal daughter, was using methamphetamine, and methamphetamine had led to heart failure or cardiomyopathy. Unfortunately, as a result of a prolonged resuscitation, a lot of CPR time where she really didn't get good blood flow to the brain, she had developed what we call a noxic brain injury, which is sort of irreversible damage to the brain. And her mother in this article very eloquently describes kind of what we call doll's eyes, which mean that the eyes sort of don't move in relation to the head and stay oriented in space, which is really kind of a very unfortunate sign that we see all too often here as well. And given the fact that she had this irreversible brain damage, they decided to withdraw life support. She died. And I tell you this story, one, for two reasons. One, this is something that's available publicly, so it's something that I can share with you. But two, to me, it really represents, the types of patients that we see all too often here. And once every other week, I'm on service taking care of heart failure patients in the hospital. About once every 6 weeks, I take care of all the cardiology patients in the hospital that UCSF takes care of. And inevitably, 2, 3, 4 times a month, we have very similar stories. Patients present from home in cardiac arrest because of heart failure that was undiagnosed and often as a result of methamphetamine use. So what is methamphetamine? So methamphetamine is an amphetamine. It's a very potent central nervous system stimulant. And it really it results in the body, or causes the body to basically release all of those adrenergic hormones all at once. So all of the epinephrine, the norepinephrine that are stored in the nerves of our cells, and the nerve ends get released all at once. The dopamine gets released all at once. And that really causes, in the short term, an elevated mood. So people feel very excited, very euphoric. They feel like they have increased alertness, increased energy. And this is often why patients with sort of ADHD are given amphetamine type drugs or amphetamine derivatives, because it, in the right small dose, can cause increased alertness and focus. However, at high dosages that are typically associated with abuse, it can cause breakdown of skeletal muscles. That should say rapid mood swings. People all of a sudden are happy, they're sad, they're irritated, they're irritable, and ultimately can cause psychosis as well, where people get very paranoid, they have hallucinations, they can't sleep at all. And it's a very, very addictive substance. I mean, people can use methamphetamine once or twice and develop profound addiction, which really rivals things like nicotine. As we talked about, this adrenergic sort of stimulation, this adrenaline, this noradrenaline, just like it does with heart failure, causes increased heart rate, increased blood pressure, and can actually cause spasm of the coronary arteries. And this means that the arteries can really clamp down and cause the same type of heart attack that occurred in Casey, which can ultimately lead to irregular heart rhythms as well. It causes decreased blood flow to the heart muscle and stress to the wall of the heart. Every time the heart has to beat so vigorously, so profoundly, and so quickly, it's overwhelming its ability to get oxygen to those heart cells. And over time, that leads to what we call apoptosis, or programmed cell death of the heart. The heart muscles are not getting the oxygen they need. They don't know what's going on. So they figure some of those cells just need to be sacrificed and die to provide additional blood flow to the other cells of the heart. Unfortunately, that just makes the heart weak, makes the heart enlarge, can cause scarring in the heart. You can develop heart failure with as little as one use. And I've had patients come in the emergency department and they swear up and down that they've only taken amphetamine one time, and they develop sort of what we call a stress cardiomyopathy. The heart fails immediately. Chronically, though, you really can get this apoptosis, this scarring of the walls of the heart, which can really lead to long-standing dilated cardiomyopathy that can ultimately be difficult to treat and difficult to reverse. So we've actually done a little bit of research in methamphetamine-associated cardiomyopathy, and this has been a lot of the research that I've done here. For example, looking at Southern California over the course of the last, between 2009 and 2014, over 5 years or so, the rate of amphetamine-associated cardiomyopathy increased threefold in just 5 years. However, even in 2014, they were only seeing sort of 6% of their heart failure patients have a history of amphetamine use. We looked at basically 1,200 patients who were diagnosed with heart failure with reduced ejection fraction here at Community Regional Medical Center. And we looked at all of those cases, we reviewed every case, and we identified those patients that had a history of using adrenergic stimulants, either methamphetamine or cocaine. And of those 1,200 patients who developed heart failure, almost 20% of them had a history of methamphetamine use, documented by a social history, which showed that they were actively using, or positive amphetamine tests while they were in the hospital, which is just sort of an astronomically high level of amphetamine use. And it really just illustrates the sort of epidemic that we're seeing, not just here in the Central Valley, but really all across the Western United States. We found that when we looked at these patients, they tended to be younger, they tended to be males more than females, they tended to be white more than other sort of ethnicities, and they had more severely reduced left ventricular systolic function. So that pump, which is normally designed to push half to 2/3 of the blood every time, for these patients was pushing less than 1/3 of the blood every time. It's just, all of these were kind of markers for a more sick or more significant presentation of heart failure. The good news is that we pretty much have a non-judgmental clinic here, and I try to treat every patient with as much respect as I think everybody's do, regardless of whether or not they use amphetamines. Currently, they've used amphetamines in the past. We've been able to really develop, I think, good relationships with a lot of these patients, help them to get support to get off amphetamines. And if a patient can get off amphetamines and can get on good heart failure medication, often we can reverse this. And most of these patients, if they're able to get on board and really participate in our program, have gone on to see their heart function get better, if not all the way back to normal. All right, and that kind of segues us into really, how do we treat heart failure? And so really, treating heart failure, we have to look at our goals. And our goals are kind of fourfold. One, we want to sort of fix that brain hormone imbalance that we talked about earlier. We want to get those stress hormone levels down. We want to get that BNP level up so that we can actually improve functional ability and improve quality of life. I mean, we can do a lot of treatments to just keep patients alive for as long as possible, but really, to me, it's not as important to keep them alive as long as possible, but to give them the best and most meaningful life possible. And so we want them to be able to do more. We want them to be able to get back to work. We want them to be able to spend time with their loved ones, go, fishing with their kids, their brothers or sisters, be the teacher mom. We want them to be able to do everything that they want to be able to do. And we do this by improving heart structure and function. And overall, we do want to improve their life expectancy. So this is an illustration by Dr. Katz, who is a kind of a heart failure guru. And it's really just kind of highlighting the different treatment strategies that we have for heart failure. And so often what we want to do is unload the wagon. We want to take the work off the heart. We want to lower blood pressure. We want to decrease fluid levels. We want to slow the heart rate down. We don't want that adrenaline to cause the heart rate to beat too quickly. We want to actually slow the heart rate down. Sometimes we need to whip the horse a little bit, and we can give medications to make the heart beat a little bit stronger, a little bit faster if we have to. And then often, what I deal with is, you get a tractor, and we have a left ventricular assist device or a mechanical heart program here. We can actually put in a mechanical pump into the heart. I'll show you an example of that in just a little bit. Or we get a new horse, and this is kind of the analogy for a heart transplant. If it's time to sort of put one horse out to pasture, you kind of have to get another horse to do the job. But ultimately, at the end of the day, what we really want to do is heal the horse, and that's what we're going to talk about next. So starting with treatment, I always like to start with what we call lifestyle modification. And this is stuff that everybody can be doing, not just patients with heart failure. And so that's one, get excellent control of risk factors. Blood pressure, we want to decrease. We want to get your exercise up. And really what we're looking at is 30 to 40 minutes of exercise on most days. Now, often heart failure patients are a little bit scared to exercise because they don't know what they want to do. And so what we try to do is get them enrolled in a cardiac rehab program where they can work with an exercise physiologist and a cardiac nurse, really to make sure that they're able to exercise safely and to the highest capacity possible. A low salt diet, we want to limit our fluid intake to no more than sort of 48 to 64 ounces per day. We want to get our weight down, trying to achieve a healthy body mass index. That's kind of our weight compared to our height. And if we can get that less than a BMI of 30, it really takes a lot of the work off the heart. There's a lot less tissue that the heart has to push blood through, making it easier on the heart and helping to achieve heart healing. And then we want to avoid cardiotoxic substances. So stop smoking, stop using meth. And what we found recently is that marijuana has a lot of negative effects on the heart as well. It causes high blood pressure and high heart rate, which we know increases the workload on the heart and can lead to heart failure. So then what we look at is medical therapy. And most patients, if the heart function is less than 40%, so every time the heart squeezes, it's pushing out less than 50% of the blood and less than 40% of the blood, then we really need to start medications. And these are medications which we'll see really address those specific hormonal pathways. All of these medications reduce blood pressure. They can help to eliminate swelling, and they can help to slow down the heart. And going back to that first slide, we can see again how we can affect change on both cardiac output and adrenergic stimulation. So what we do, we want to block the effect of adrenaline, so we use adrenaline blockers, and these are beta blockers. These are commonly used medications for high blood pressure, for anxiety, for high thyroid, which can really help to slow the heart rate down. It decreases how strenuously the heart has to contract. It can really help to improve blood flow to the heart. We also use what's called Rasp Blockade. So these are ACE inhibitors, your lisinoprils, ramiprils, angiotensin receptor blockers, valsartan, losartan, candesartan, and mineralocorticoid receptor antagonists. These are your spironolactone, aflibercept, Inspira. And these medications relax blood vessels, get rid of salt water, and really help to decrease the workload on the heart. Again, getting rid of salt water, we use water pills, furosemide, bumetanide, thiazide, chlorothiazide. We use a newer class of medications called SGLT2 inhibitors, which get rid of sort of sugar through the kidneys, and that sugar pulls the water with it as well. And then a newer class of medications called neprilysin inhibitors. And this is part of a medication that's called an angiotensin receptor neprilysin inhibitor. You might see commercials for something called Entresto, and that's the only medication of its class that does this neprilysin inhibitor. And what we'll see, neprilysin inhibitor, in addition to causing sort of excretion of salt water really increases the amount of time that the BMP stays in circulation. You guys remember that B-type natriuretic peptide helps to get rid of salt water, helps to lower blood pressure, relax blood vessels, and helps the heart to beat more efficiently. Everything we want in a heart failure medication. And neprilysin inhibitors help to allow that hormone to last longer, so it has a more profound effect on the body. All of these medications have been associated with not only helping the heart to heal and recover, it helps reduce the chance of going into those irregular heart rhythms that result in sudden cardiac death, and helps people to live longer. If we put all of these medications together, we can decrease the chance of dying by 70% if the patient actually follows the program. So again, it's just like cancer, this is our chemotherapy, and results in a happy, healthy heart. All right, so what are some of the other treatments for heart failure? And I want to rush through this a little bit because I just want to be able to answer your guys' questions. So you might have seen people who have a little bit of a bulge on their chest wall. This is usually a pacemaker or sometimes a defibrillator. This is, I like to describe as a little sort of guardian that just sits there on your shoulder, monitors your heart, doesn't actively do things all the time, but if it notices one of those ventricular arrhythmias, ventricular tachycardia, those very fast short circuits of the heart, can actually shock the patient and bring it out of that arrhythmia, and helps to allow people to live longer. This is a pressure sensor, what we call CardioMEMS. This is something that we do here. Well, we do all these therapies here with the exception of heart transplant. But this helps us just to keep an eye on the patient from home. They can basically, go home, they lie on a pillow, it has a little sensor in the pillow, and it tells us kind of what the fluid level is in the heart. And we can follow this from day to day and adjust the patient's medications depending on what the fluid levels are, giving them an ability to stay home but still have a better quality of life, free of congestion, and they're able to live longer with this therapy. This is that left ventricular assist device. This is, or some people will describe it as a mechanical heart. It's basically a pump that gets surgically implanted into the tip of the heart. It pulls blood from the left ventricle, goes through a little rotary pump that then injects the blood back into the aorta, and can basically reproduce the same horsepower of the heart that the heart would normally have by itself. And it can also help the heart to provide a normal cardiac output. This therapy has been associated with giving patients back not just years to their life, but also quality of life. So I've had patients receive these types of pumps, and they've gone from being mostly bedbound, mostly in the hospital, to being able to go back to being wives and husbands and moms and sisters and daughters, and really going back to, giving back to their community and just living, getting back to work, and just really feeling like they're contributing to society again. And then ultimately, kind of when all else fails, then we can go on to heart transplant. And one of the things I'm probably most proud of with our program is that we've really sort of increased the opportunity for heart transplant. We don't do transplants here yet, but we've gone on and we've had sort of 25 patients go through our program, most of them not even receiving LVAD or any significant sort of mechanical heart pumps, but we've sort of gone through the evaluation process, got them primed, and then sort of aligned them with transplant centers throughout the state to really go on to receive what is really the ultimate gift, which is sort of the gift of life, through the organs of someone who's deceased. And really, I've seen this sort of give patients back decades. I had a patient in my office today, right before I came up here, who's now 17 years past her heart transplant, and is living every day like it is really the gift that it is. And so it's just important to really think about this when you guys are renewing your licenses, and to make sure you check that box to be a solid organ donor. All right, so these are my kids. This is RJ, this is Jackson, and that is the conclusion of my talk. And so now I hope we have some questions. And so I'm going to turn it back to Dr. Dellen and Summer, and hopefully we can answer any questions you guys may have.
Thank you, Dr. Kiel. That was really good. There's a couple questions that are on the Q&A. There's a question about children that take stimulants for ADHD or ADD. What are the long-term effects of these medications on the developing body? Yeah,
so I think the data on amphetamine derivatives like methylphenidate or Ritalin and medications like that show that those can be actually very beneficial to kids who truly have ADHD. ADHD really is a deficiency of dopamine secretion and substantia nigra in the brain. So your brain's not producing enough dopamine. It's not stimulating the brain enough. It's not stimulating the front part of the brain, which actually controls behavior. And by causing some secretion of that hormone, you're actually able to provide kids back the ability to provide attention in school, and they're actually able to actually do much better on average. Part of sort of a treatment program. So I don't want us to demonize or stigmatize all amphetamine derivatives. There is some suggestion that in certain sensitive people over time, some people can develop some cardiotoxic effect. These are dosed at lower dosages that don't typically result in some hypertension, high blood pressure, high heart rate. But if people are already sort of on the higher end of those types of parameters, it can cause excessive blood pressure and heart rate. So that has to be monitored. Really, the prescribing physician should be routinely discussing with these patients symptoms of heart failure. Are you getting short of breath when you lay flat? Do you have swelling in your legs? And rarely they have been associated with developing both pulmonary hypertension, which is abnormally high blood pressure in the lungs, and heart failure. But this is rare and shouldn't preclude kids from getting this medication if they truly do need it.
Okay. There's another question that sort of follows that somebody used to take, they said methamphetamine, but I think they meant amphetamine derivatives for ADHD. Will that affect their body in long term in any way?
Yeah, again,
in their heart.
properly dosed and properly monitored, those can be safe and effective medications. But again, it's just important to be aware of the side effects, and that's something that should be commonly discussed between the prescribing provider and the patient. And if any of those symptoms do start to manifest themselves or do start to show up, then that should prompt a visit to that provider and evaluation for heart failure or other structural heart disease.
Perfect. Yeah, I think that's basically it, Dr. Keel. Thank you very much for your great talk. That was really nice.
Okay.
All right. Really appreciate it.
My pleasure, guys. I really enjoyed it. If you guys are interested, Dr. Roytman gives a fantastic lecture. So I think you guys get a 15-minute break.
We're actually going to just jump right in. We're going to keep them going.
Oh, did I run over?
Just a little bit, but it's fine.
Oh, I'm so sorry.
Don't worry. It's okay.
Okay, I thought they had till 6:15. Okay, I'll get off. Bye
Yeah,
now.
totally. Okay, you're good. Okay, thank you. All right, everybody. I hope you enjoyed Dr. Keel's lecture. It was a great lecture. I learned a lot as well. All of these lectures teach me a little bit every day, or it's a good review at least. So that's nice. I'm going to go ahead and introduce Dr. Roytman, and then we'll have her get started and take over the stage. Sorry that I won't be able to give you guys any break. Just stretch your legs real quick as I introduce Dr. Roytman, and then we'll go from there. So Dr. Roytman actually is one of our internal medicine physicians who specializes in hepatology, so liver disease, and she's great, and I'll tell you a little bit more about her. So she received her medical degree from Oregon Health Science University, and then completed her residency in internal medicine at Mount Sinai Hospital. She joined the University of here, UCSF Fresno, in 2017 as a clinical professor of medicine for the Department of Medicine and as a director for the liver program in the division of gastroenterology, hepatology, and nutrition. So that's a very specific field, which is amazing. She's involved in research for hepatitis B, hepatitis C, drug-induced liver injuries, non-alcoholic steatohepatitis, so you can get non-alcoholic liver injury. So something that she's also done research in, cirrhosis and liver fibrosis, which is amazing. She loves teaching hepatology, of course, to all level learners, from patients to providers. Some fun facts about her. She came to US from Soviet Union, which doesn't exist anymore, when she was 16 years old. And to add on to that fun fact, I moved from India when I was 16 years old here as well. And I did not know English like Dr. Roytman either. That's pretty amazing. Her first job in the US was as a nurse aide at a state nursing home at the age of 17, which is pretty amazing. She likes hot yoga and is crazy about downhill skiing. I don't do any snow sports. That's amazing. And she's terrible. She says she's terrible at organized sports. I'm not so sure about that. I'm gonna let Dr. Roytman take over and go from there.
Well, thank you so much for the kind introduction. I am indeed terrible at any organized sports. I cannot make my hands and feet work together. But fortunately, in medicine, at least in internal medicine, this is not a required skill. So let me pull up my slides and we'll jump right into it. Okay, and now we're cooking with fire. All right. So my talk is based on one of my favorite books by Dr. Seuss, All the Places Will Go, Hepatitis C in 2020. Believe it or not, I've been giving this talk for close to a decade. And the first time when I gave this talk, I think it was in 2011, I gave it to a group of medical students or medical student class. And I told them, you know, we have this terrible disease called hepatitis C. It's deadly. There's no cure for it or no good cure for it. But you know what? The scientists are really working on a cure for it. And hopefully when you are grown-up doctors, you will be able to take care of your patients. You'll be able to cure them. So the year passes and it's my turn to do the talk again. And guess what? At that point, we had the cure for hepatitis C. So I had to completely rewrite my talk. And I've had to completely rewrite my talk every single year since then that I've given them, because the progress in hepatitis C management has just been remarkable. So we've gone from the hepatitis C being this big scary thing to something that is very manageable and remarkably curable. So what should we learn today? We're going to talk a little bit about what does the liver do? What are the things that can damage our liver? What is hepatitis C, which is obviously one of the things that can damage our liver, and who is at risk for it? We'll talk about diagnosis, and most importantly, we'll focus on the treatment for hepatitis C. And I want to explain to you the difference between treatment and cure. There are very few diseases that we can cure. So for example, heart failure, we cannot cure unless we give the patient a heart transplant, right? But we can treat it really well. We can give patients medications, we can make them feel better. So this is called treating the patient. Curing the patient means that you've gotten rid of the disease and it will never come back. And this is what we can do with hepatitis C, which is remarkable. So for those of you who pay attention to the news, the Nobel Prize for Medicine was awarded last week for hepatitis C discovery. And totally cool, I got to meet Dr. Harvey Alter several years ago. He's a remarkable person. And not only did he discover hepatitis C, he also discovered hepatitis B. Like seriously, who does two of those things in lifetime? It was just that one time that you won the Nobel Prize, wasn't that dear? And so I do hope Dr. Harvey Alter wins another one for hepatitis B. Congratulations, today's your day. You're off to great places. You're off and away. We're about to learn about certainly what I consider the coolest thing that happened in my career in medicine. So first of all, where is the liver? So the liver is located under our right rib cage, and a normal healthy liver is pretty much hides under the ribs. So you wouldn't be able to touch it or palpate it, but it's about the size of the football roughly. The liver does a few very important things. So first of all, liver works as a body's factory. It makes protein that helps your body be nourished, and it also makes protein that helps your blood clot. For example, if you have a cut or any other type of injury, the liver makes the protein that helps you make that little scab so the blood doesn't continue to pour out. It also removes toxic substances from your body along with the kidneys, okay? So what happens if our liver is damaged, okay? So initially the liver may get swollen. You can feel it below the ribs, or most often the physician who's examining you may feel the liver below your ribs. If the damage is serious, or especially if it goes on for years and years, the liver develops scarring and becomes hard and shrunken like a raisin. This is called cirrhosis, which literally means a lot of scarring, okay? So this is how the normal healthy liver looks. See, it's nice and smooth and shiny. And this is how a cirrhotic liver looks. So you can see the little cartoon implies that the drinking causes liver cirrhosis, and excessive drinking absolutely causes liver cirrhosis. But there are lots and lots of other things that may cause liver cirrhosis or liver damage that doesn't happen in the drinkers. and hepatitis C is one of them. So I always want to make sure when patients come to my office and they bring, especially if they come with family, I want to make sure that I reassure them that I know they are not a drinker. I know that they have developed cirrhosis for a different reason. And I think patients appreciate that. So what are the physical signs of liver disease? Physical exam, I think, is, first of all, something really, really remarkable, because you can look at the patients, and I have the same bad habit that Dr. Keel has. I also look at patients in Costco, and I also try to diagnose them with liver disease like he does with heart failure. But it's really something that you can do for your patients without needing to get blood tests, without needing to get ultrasounds or CT scans. This is something you can do and you can learn just by looking at patients and examining them. So first of all, you can develop yellowing of your eyes and yellowing of your skin. This is one of the signs of advanced liver disease. Patients who develop advanced liver disease or cirrhosis tend to lose muscle mass. You can see that this gentleman's, you can see all the bones in his face. This is called muscle wasting. These little spots develop on the skin, oftentimes on the chest or the shoulders or the upper back, and they're called spider angiomas. They are one of the signs of a hormonal imbalance in patients with cirrhosis. This, take a look at the shape of these nails. It looks very abnormal. This is called nail clubbing. Again, one of the signs of liver disease as well as advanced lung disease. This is breast enlargement in a man. Obviously, men not supposed to have enlarged breasts, but there's an imbalance between the male and female hormones in patients with liver cirrhosis, leading to this, very bothersome symptoms for our male patients. This is called caput medusa, and this is the enlargement of the veins that one can develop in the setting of cirrhosis. This is another picture that we've already talked about, liver being hidden behind or under the rib cage. And a similar picture on the other side, on the left side of our body, there's an organ called the spleen. And normal spleen, again, also cannot be seen under, cannot be felt under the ribs. But in cirrhosis, the liver causes spleen enlargement, and the spleen can be felt sometimes all the way down into the patient's pelvis. Okay. This is called ascites. Ascites is an accumulation of fluid in the abdomen. Dr. Keel had shared with us that this happens in patients with heart disease. This also happens in patients with liver disease. In fact, oftentimes, when the physicians initially sees the patient, he can't know, which organ is to blame for it. And we need to sample the fluid, take a small needle, get a sample from the fluid, and figure out by doing certain fluid analysis, which organ is causing the problem. Okay, so what are the things that can damage our liver? So certainly alcohol, and alcohol remains a #1 cause of liver damage in the United States. The viral hepatitis, so let's break it down. It's a Latin word, and it comes from 2 words. Hepa means liver, and itis means inflammation. Itis is a super useful word to remember, because you can recognize itis in so many other diseases and conditions, diverticulitis, pharyngitis. All the itises just means there's something inflamed in a different part of the body, okay? So viral hepatitis means that there's a virus infecting the liver, and we have A, B, C, D, and E viruses. And today we're going to focus on the hepatitis C virus. There can be a non-viral hepatitis, for example, something we call the steatohepatitis. Steatohepatitis is a fancy word of saying fatty liver, or fat, accumulation of fat affecting your liver. So excess weight may lead to the liver damage similar to hepatitis or viral hepatitis or excessive drinking. So hepatitis C, this is a viral particle. It's a single-stranded linear RNA virus. You don't need to remember that part, but what you do need to kind of pay attention to is what this virus is capable of. It is pretends to be part of us. It mimics our cellular machinery, and it hijacks our own cellular apparatus to make more of itself. And that's a unique characteristic of the hepatitis C virus. And remembering that will help us understand how we came up with a cure for hepatitis C. So in terms of statistics, it was identified by Dr. Harvey Alter in 1989. It was previously known as a non-A, non-B, post-transfusion hepatitis. The screening first became available in 1992. This is an important date to remember because patients who have been exposed to blood products or had surgery before 1992 are at risk for being infected with hepatitis C. It can be transmitted, and most often is transmitted in a blood-to-blood transmission. So it can be transmitted through a blood transfusion, which essentially non-existent nowadays because we screen all the blood products. And most often it's being transmitted via intravenous drug use, or can also be transmitted through intranasal snorting of drugs, the snorting of cocaine. Because when you share what we call a paraphernalia, the stuff that you need to use to take the drug into your nose, this can have little droplets of blood, and this can be passed from one person to another. And that's how you can get hepatitis C. Rarely, it can also be transmitted from mom to baby. That's not a major part of the hepatitis C transmission. There are 6 genotypes. We'll talk some more about the genotypes. Vaccine, we hear a lot in the news about vaccine for viruses, is not available for hepatitis C, and it's not likely to be available, certainly not in my lifetime, maybe in your lifetime. But the reason it's not available, and it will not be available, is the virus is very tricksy. It can mutate really rapidly, and it's hard for the vaccine to find a stable target to log on to. But fortunately, again, we have cure. So the problem with hepatitis C is there are so many people who don't know that they have it. There are anywhere from 2.7 million to 3.4 million, depending on who you ask, of patients who have hepatitis C. 2 years ago, back in 2018, only a quarter of these patients were aware of the diagnosis. Only 5% of these patients were treated. The good news, though, is those who were treated, vast majority of them were also cured. So the important thing to know about hepatitis C, that it is a chronic progressive disease. So to go from a healthy liver to liver with some scarring and to with a liver to a lot of scarring takes years and sometimes decades. The virus can literally be present in our bodies for 20, 30 years and not cause any symptoms, which doesn't cause the patients to seek medical attention until they get to the cirrhosis stage. So this is certainly a challenge in diagnosing and treating hepatitis C. So why is hepatitis C curable? How come we can cure hepatitis C, but very few of the other diseases? So bear with me. So this is a cell in our bodies. This is a nucleus. And inside the nucleus is the human DNA, right? What the HIV virus does, it integrates into our own human DNA, and the drugs cannot get it. In hepatitis B, we have the same process of integration into our own human DNA, and it also forms this very stable molecules called cccDNA, circular covalently closed DNA molecule, and these molecules also live inside of the nucleus, and it's very hard for the drugs to get at that one either. In hepatitis C, we are very fortunate that the virus does not integrate, it does not form this funky cccDNA molecules, but it lives outside of the nucleus in the cellular cytoplasm. So the drugs can easily come in and kill the virus, and it will be dead forever. It will not come back, it will not hide anywhere, it will be gone. So who is at risk for hepatitis C? So you may have been paying attention over the last few years that we've talked a lot about baby boomers. Baby boomers are those that are born between 1945 and 1965. And we found out that those patients were at a higher risk for hepatitis C. So why is that? Well, probably multiple reasons, right? This is the time of the Summer of Love. This is the time of the Vietnam War. So many, many reasons for that. So what the CDC, Center for Disease Control, decided several years ago is instead of really having this uncomfortable conversation with those patients who are getting older at this point about what they've been doing in the Summer of Love, we will simply go ahead and make a recommendation to screen all of them. All baby boomers should be screened one time for hepatitis C. And if we find that they're infected, we can treat them. So we were coming along and doing great with the baby boomers treatment. So this is another graph that shows you that in 2007, indeed, the baby boomers were the major problem. Now, fast forward to 2015, and the graph looks really different. Like, whoa, what has happened here? And what has happened here is the opioid epidemic. And the opioid epidemic primarily affects people in their 20s and their 30s. And the rates of hepatitis C just has skyrocketed in this population. So this is another look at it. What we're seeing here is among people ages 18 to 29, the hepatitis C, new diagnosis of hepatitis C increased by 400%. Among people ages 30 to 39 by 325%. I mean, these are wild increases that just happened in the last few years. So what the CDC recognized that, and in March of this year, they say, let's not worry about the baby boomers. Let's just screen everyone. Older adults, ages 18 or older, just need to be screened. This is very simple. When you go to the doctor, you get checked for diabetes, you get checked for cholesterol, and now you're going to be checked for hepatitis C. So very easy. The other recommendation the CDC has come up with is all pregnant women should be screened during pregnancy. We're already screening all pregnant women for hepatitis B, so hepatitis C is just an add-on. So how do we diagnose, how we detect it? It's very simple. The first step is we look for something called hepatitis C antibody. If the hepatitis C antibody is positive, then the secondary test looks for the presence of the virus as well as the genotype. And the last step is trying to determine how urgent is it to treat the patient, how much scarring is in their liver. Okay, so we'll talk about all of these. So hepatitis C antibody test, basically it's the footprints of the virus in your blood. If it's positive, that means that the virus has been there at some point. It doesn't necessarily mean that it is there because about 20% of the patients clear the virus on their own. So, but the footsteps remain. So it's necessary to test further to figure out if active viral infection is present. And this is where the hepatitis C RNA tests come in. We use PCR to determine that. And if you have the virus, you have chronic hepatitis C. How much virus? It actually doesn't matter. Some people have a lot of virus and very little liver damage. Some people have very little virus and a lot of liver damage. But if you have the virus, it will cause damage and it should be eliminated. Okay, genotypes. So genotypes are different strains of virus, just like there's different strains of humans. There's 6 known genotypes. All pretty much have similar effects on the liver, with one exception of genotype 3 that is also associated with the development of fatty liver. In the past, some genotypes were harder to treat, some were easier to treat, but the treatment has advanced so far that it probably doesn't dramatically matter of what genotype you have. So it's kind of a nice to know at this point. So genotypes are interestingly distributed around the world. So if we look here in the United States, we have primarily genotype 1. We have a little bit of genotype 2 and 3. If you look at Southeast Asia, we see that there's quite a bit of genotype 6, especially in Vietnam. So when I see patients from Vietnam in my office, oftentimes they actually have the genotype 6 and not the commonly found genotypes 1, 2, and 3. What is going on here? What is with this green sign? This is in Egypt. Egypt has the highest prevalence of hepatitis C in the world. This is quite an achievement. And all of Egypt's genotype, all of Egypt's hepatitis C is genotype 4. So how did it happen? What in the world went down with Egypt? So what happened was that in Egypt, back in the 1940s and 50s, there was an epidemic of another condition called schistosomiasis. Schistosomiasis is caused by parasitic flatworms. And flatworms, this type of flatworms, can cause terrible problems. They can cause liver scarring, they can cause kidney failure, they can cause bladder cancer. So this is a picture of an 11-year-old boy with ascites, right? Like we talked about before, but in his case, it's due to this infestation by flatworms. So the government of Egypt wanted to eradicate schistosomiasis, a very good undertaking. They decided that they're going to treat everybody with this intravenous tartar emetic. And this went on from the 1950s into the 1980s. Each treatment required 10 to 12 intravenous doses of this tartar emetic. Unfortunately, the equipment, the needles to administer this treatment were used over and over and over again. And while we were successful in eliminating schistosomiasis, unfortunately, vast numbers of Egyptians got infected with hepatitis C genotype 4. Since that time, the government of Egypt has done a remarkable job in eradicating hepatitis C. So the last point in evaluating a patient with hepatitis C was figuring out how much scarring is in the liver, right? This is important to know because if you only have very little scarring, we get rid of your hepatitis C, you're going to be totally fine. If you have a lot of scarring, you may be at risk for developing liver cancer, and we need to keep a closer eye on it. So how do we do it? So this is called vibration controlled transient elastography, also known as FibroScan. It's a relatively new and very exciting technology. So we're gonna think of the liver here for a second as a rubber ball, okay? The rubber ball, if it's a healthy liver, is nice and soft and squishy. If we're gonna send a sound wave through the rubber ball and it's soft, the sound wave is gonna go fairly slowly. It's gonna take its time, okay? If the rubber ball is hard, like a cirrhotic liver or scarred up liver would be, the sound wave is gonna go a lot faster. So what we can do is we can correlate the speed of the sound wave travel to the degree of hardness of the liver. The faster the sound wave travels, the more the harder the liver is, right? So you can see the sound wave traveling, it's coming back, it's measured by the same device that generated the liver, and in 10-15 minutes, you know how much scarring your patient's liver has. Now, moving on to how to treat, okay? You have brain in your head, you have feet in your shoes, you can steer yourself in any direction you choose. You are on your own and you know what you know, and you're the one who will decide where to go. So I will teach you guys how to treat the patients since you're gonna be ultimately the treaters. Okay, so we figured out that hepatitis C is a problem somewhere in the early 90s. And then we jumped up and decided to treat it with interferon. Interferon is a terrible drug, right? We've tried it on many, many illnesses, very few of them successful. It makes you feel like you have a flu. And who wants to have a flu for 6 months or 12 months, right? It's just a terrible drug. And when we first started with an interferon and we treated the patients for 6 months with it, we got a glorious cure rate of 6%. Not really exciting. And then we did a bunch of different things. We combined interferon with other drugs. We got maybe to 50%, but the patients were just absolutely miserable, okay? So like, again, the side effects, flu-like symptoms, you become anemic, you become depressed. Again, ribavirin, which is one of the add-on drugs, can cause further anemia, and it can actually make patients with advanced liver disease even worse. So clearly not working for us here. Okay, so this is a hepatocyte or a liver cell, okay? This is the virus particle, hepatitis C virus. It gets engulfed by the hepatocyte. It uncoats, it literally takes its coat covering off. And then remember how we talked about hijacking the cellular machinery? It hijacks our own cellular apparatus to make more of itself. This thing over here, it's called a polyprotein. A polyprotein is necessary to make more virus. but polyprotein cannot function as a whole thing. It needs to be sliced and diced in different parts. So the thought was, what if we try to target with our drugs all those different parts of the viral machinery needed for propagation? Well, we first started with this one, the protease inhibitor, and the drug was not amazing. The virus could mutate very easily and avoid this drug. Then we tried this one, then NS5A. That was a little better, but the best one was this one, the NS5B polymerase inhibitor. The reason it was such an awesome target for the drugs is because this site is very conserved in the virus. In other words, it's vitally, this piece of equipment is vitally important for the virus. It cannot mutate without dying and to avoid this drug. So the sofosbuvir is an NS5B polymerase inhibitor, and it was a true game changer. The study first came out in New England Journal of Medicine in 2013, and it looked at 12 weeks of therapy of sofosbuvir, still with an interferon and still with ribavirin. But look at the cure rate. We suddenly went from 40-50% cure rate in 12 months of misery to a 90% cure rate with just 12 weeks of therapy, and only 2% of the patients stopped taking it because they couldn't tolerate it. So that was pretty amazing. The FDA quickly approved it. But the problem was we still had lots of patients who couldn't be treated with this regimen. Patients with bad cirrhosis, right? We couldn't put them on interferon. Patients with renal disease. You cannot give interferon or ribavirin to patients with renal disease. They will become very, very anemic. There are patients who simply cannot tolerate interferon. Patients who've had transplants, you cannot give them an interferon because this is going to lead them to reject their organs. So lots of unmet needs. So then there was this new drug that came out called cimeprevir. And cimeprevir is the protease inhibitor. And remember I told you about the protease inhibitor, that this wasn't a very exciting drug, right? The virus could mutate to evade it. Cimeprevir still had to be used with interferon and ribavirin. So nobody was really excited about this one, okay? But then somebody thought, hey, excuse me, I'm gonna let it pass. Okay, moving on. So somebody thought, what if we combine this not so interesting drug with this very interesting drug, and they're both oral medications, right? Easy to take, few side effects. I wonder what would happen. And this is, sorry.
I recognize that noise so well.
Exactly, exactly. We recognize it in our sleep and jump right out of it. So anyway, Cosmos. The reason the Cosmos study is so famous is primarily because of how few patients it included. So look at the right side of the slide. This group of patients that received just these two drugs, there were 14 patients. You hear about thousands of patients being enrolled in clinical trials, right? But this had 14 patients. But guess what? 13 out of 14 got cured. So the hepatologists got pretty excited because we had patients who were dying and we had nothing to offer them. We were like, hey, why not? Let's give it a try. So this is what's called off-label prescribing. This drug combination is not approved by the FDA to be used together for this indication. This is called off-label prescribing. You don't go to jail for it. It's used very commonly, but it's kind of nice if somebody tells you this is a good idea to use it. So ASLD, which is our parent organization, supported the use of this off-label prescription. And then FDA kind of caught on to the fact that everybody was doing it anyway, so they might as well approve it as well. So this happened in 2014. Okay, So since this combination worked so remarkably well, why don't we try more combinations and see what happens? So this is our protease inhibitor. This is our NS5A drug, and this is our NS5B drug. So we can combine, we don't want to combine two of the same, but we certainly can combine the protease inhibitor plus NS5A. We can combine NS5A plus NS5B, and some of those names may sound familiar. This one is Harvoni. You probably have seen advertising on TV for Harvoni. This one is Epclusa. This one is Mavoride. So all of these medications are now all oral medications that can be used to treat hepatitis C. The waiting place. We cannot treat everybody at the same time, right? So everybody's just waiting for the fish to bite, or waiting for a wind to fly a kite, or waiting around for a Friday night, or waiting perhaps for Uncle Jake, or for a pot to boil or a batter break, or a string of pearls or a pair of pants, or a wig with curls or another chance. Everyone is just waiting. So what should we do? What can our patients do while we're waiting? Well, you don't want to do anything that can damage your liver further. No alcohol, no smoking, no marijuana. Marijuana is actually known to cause disease progression or faster disease progression in patients with hepatitis C. Avoid gaining excess weight. Remember, fatty liver disease can be just as bad as hepatitis. Eat healthy. Avoid unnecessary dietary supplements. Those can cause liver damage as well. And I see, unfortunately, many patients that are in that situation, and get tested for other things such as HIV or hepatitis B. And if you're not immune for hepatitis B, you should certainly get vaccinated for it, as well as for hepatitis A, influenza, and pneumonia. Okay, so well, if I have hepatitis C, how can I protect those that I live with? So we do not want to share anything that has a potential for blood-to-blood contact. And some it's kind of obvious, right? Don't share needles or don't use needles, period. But you also want to avoid sharing toothbrushes, nail clippers, razors, small chance of it, resulting in an infection, but we just want to be on the safe side, right? If you bleed, you want to clean it up, cover the wound. Okay. The good news is that it's very safe to touch, kiss, and hug your family and friends. You cannot transmit the virus that way. It is also safe to share cups, plates, and utensils. Again, virus cannot be transmitted that way. And the best news is that hepatitis C can be cured in a simple regimen, all pills, no injections, no interferon, in about 8 to 12 weeks, with a 98% chance of cure. If we cure the patients, it will stop progression of liver disease, and the liver can regenerate. It's actually the only organ that is really good at regeneration. So what have we learned today? We learned that the hepatitis C is common. Only a fraction of patients know about it, and even fewer are treated. CDC, Center for Disease Control, recommends testing all patients over the age of 18 as a one-time test, regardless of any risk factors. And hepatitis C can be cured in 8 to 12 weeks. And this is just totally amazing, I think. And this is a slide just to show you the progression of where we started with a 6% cure rate in 1991, all the way to the 95+% cure rate as we are now. And will you succeed? Yes, you will indeed. 98.75% guaranteed. You're off to great places. Today's your day. Your mountain is waiting, so get on your way. And I want to acknowledge my mentor, Dr. Naoki Tsai, and Dr. Theodore Seuss Giesel, whose book I used. Thank you.
Thank you, Dr. Roytman. That was awesome. While I'm going to let participants to come up with some questions, if they have any, I'm going to ask a couple questions here on my end, if that's okay with you. What is one of the most, now that you've been at UCSF Fresno for a while, is there anything specific challenges that you've seen with population here that you didn't face anywhere else or where you trained? Have you noticed a difference? Like what are the specific challenges of this community?
Absolutely. Well, unfortunately, this community is rich in challenges, right? As far as the hepatitis C is, there haven't been enough providers to treat hepatitis C, right? That's number one problem. When I talk to my colleagues in the Bay Area and San Francisco, they have cured all of their patients. They're done. Like, I still diagnose and start new treatments on several patients a week. So we're certainly nowhere close here, right? Other challenges that we have here is our really unhealthy eating habits, right? We have a lot of obesity here. We are not super fond of exercise. So fatty liver is a much bigger problem here than in other parts of the country.
I know that's so true. And another thing that usually comes up, patients in the ED always ask me, or they're concerned about, is the treatment, how much it will cost for Hep C treatment. Is there some sort of government support, or are there any other support that these patients can get if they can't afford Hep C treatment themselves?
Right. So hepatitis C is expensive. When it first started, the magical combination that I told you about, that one cost, believe it or not, $150,000. That was crazy, right? So fortunately, the prices have calmed down since then. So probably the average treatment cost is about $30,000, which is still a crazy amount of money. But if you have medical insurance, it will be covered, right? In California, we're actually really good about giving patients access to hepatitis C treatment. If you're uninsured, or if your family members are uninsured, in that case, there's still options. And those options include having your physician, someone like me, ask for you from a company that makes these drugs to have it covered. And I've been successful in getting that done as well.
That's so great. Thank you. Because that's something that always comes up, and try to explain that to the patients, because they're always fearful about that, right? Especially if they're undocumented, they're always concerned that they don't know how to approach anybody and how to get help. And I think that's some information that it's helpful to share with the community for sure. One of the things that I see in the ED that I just want to share is I see a lot of young people with, like you said, the steatohepatitis, of course, that's one of the NASH, one of the reasons. And the other one is alcohol, very, very young people who come in with alcohol liver failure related, and then they end up getting kidney damage and all that kind of stuff. And they're super young, and it's very unfortunate. I think something that our community struggles with, just because I think just the challenges that's one of another unique challenges I think here that we do see for sure, or liver failure from heart failure over time that I have seen quite a bit in our community with meth abuse and stuff like that. Have you noticed that at all here?
Absolutely. I was hesitant to bring it up, but since you brought it up, what we've seen most recently in the hospital is, like you said, a lot of young patients get admitted with a condition called alcoholic hepatitis. You remember, right? Hepa, liver, itis, inflammation caused by alcohol. And this is actually kind of a rare thing under normal circumstances, but it's been over the last few months, we literally have been overrun by alcoholic hepatitis. Yeah. And I think the people are unfortunately coping with the stress of the pandemic, the stress of, losing your job, not having a secure place to live, by drinking. And this has caused this epidemic of alcoholic hepatitis to just spiral out of control.
Yes. Yeah, no, that's so true. Hopefully we can get through this sooner than later and get back to our normal lives. Yes. Well, thank you, Dr. Roytman. That was really, really helpful. We really do appreciate you taking time to come present. Everybody in the comments section is very thankful. And some of them actually attended your liver expo this weekend.
Hi,
that's awesome. Yes. So they got double dose of you, which is perfect.
Yes. Great. I'm so happy to see that.
Yes, totally. Thank you. Thank you very much.
All right. Thank you. Good night.
Good night. All right, everybody. Thank you for joining us this week. Next week, our plan is we're going to have 2 speakers. Our first one is going to be Dr. Peterson. And for the second one, it's going to be what was I going to say? Second one is going to be a panel. So it's going to be Dr. Bond, who will talk about his involvement with medical students with the PRIME program. And then we'll have a panel with current medical students and a couple residents, including myself, with the recent graduation from the residency program here. And we'll talk about our journey, medical journey, and any questions you have. So it's going to be very much an open panel. So all those questions that you guys ask about, you know, what extracurricular activities did we do during undergrad? What kind of help did we had at Fresno State or local colleges? Who can you reach out to? What does this process involve? We will have a about 30 to 40 minutes open for Q&A next week to answer those. So that's where we're hoping to get that done, and we'll go from there.
Perfect. Thank you so much, Dr. Dillon, and thanks to all of our speakers. It looks like everybody really enjoyed them, and I'm happy. They're incredibly talented physicians, and we're lucky to have heard from them tonight. So thank you all for attending. Thank you all for chiming in. We appreciate to hear back from you, and we hope you'll join us for next week. It's going to be really informative. So for those of you that are either on your way to a medical career or considering it, I think it's going to be really, really helpful. And it's going to be fun to hear from some either, you know, current students and residents now, or those who just recently went through it. So you'll get to ask all of your questions then. So think of them now, write them down, be ready for them next week, and we'll give you plenty of time for Q&A. So hopefully that'll be a good time. But yeah, thanks everyone for joining us for session 5, and we look forward to seeing you for the big finale. Woo, session 6 next week. So thanks everyone. Have a nice evening.
Bye.
Bye-bye.